Today our topic of discussion is tonsillitis. This is a very important topic. You should be knowing that tonsils are actually two in number and they're present between the anterior and posterior pillar. The anterior pillar is the palatoglossal arch and the posterior pillar is the palatopharyngeal arch. Actually, when we open the oral cavity and we are able to visualize the tonsils, these are not the tonsils. These are a part of tonsils. Actually, the tonsils are large in size. They are extending upwards into the soft palate, they extend downwards into the base of the tongue, and they extend anteriorly into the palatoglossal arch. The tonsil is having a medial aspect and a lateral surface, an upper pole and a lower pole. The medial surface is related with the oropharynx, and it is having an epithelium which is stratified squamous epithelium, and it is having crypts, a lot of crypts, but the largest crypt, or we would say the deepest crypt, is the crypta magna or the intratonsillar cleft, right? The lateral surface is having a well-defined fibrous capsule, and in between the capsule and the bed of tonsil there is loose areolar tissue, and this is known as the peritonsillar cavity or area where the peritonsillar abscess can form, right? The upper pole extends into the soft palate, the lower pole is attached to the tongue, and the bed of tonsil is very important. The bed of tonsil is actually related to the superior constructor muscle, the styloglossus muscle, and the glossopharyngeal nerve and the styloid process, right? And the blood supply of tonsil is very important because when you are doing tonsillectomy, you have to keep in mind that the blood supply of the tonsil is majorly the tonsillar branch of facial artery, and any sort of hemorrhage will lead to serious complications. Venous drainage is the paratonsillar veins, common facial vein, pharyngeal venous plexus. Lymphatic drainage is the jugular-digastric node. The nerve supply is the cranial nerve 5 and the cranial nerve, glossopharyngeal nerve, which is the 9th cranial nerve. You just have to mainly remember the blood supply, right? The functions of tonsil, everyone knows that they are providing the local immunity, the surveillance mechanism, and they are most active from 4th to 10 year. Now comes our clinical aspect, which is acute tonsillitis. You should be remembering acute and chronic tonsillitis all depends on the duration. Acute tonsillitis is having different types. There are 4 types. One is the superficial tonsil or the catarrhal tonsillitis, follicular tonsillitis, parenchymatous tonsillitis, membranous tonsillitis. Each type is having a characteristic sign, right? This type, which is the superficial tonsillitis, is a part of generalized pharyngitis. That is not that much important, or we would say that is just side by side with pharyngitis. In follicular tonsillitis, the characteristics that you see is yellowish spots on the tonsil. As you can see in this particular picture, yellowish spots are seen. And in real picture, these are the tonsils. You're seeing yellow U-shaped line. This is actually yellowish spots. This is acute follicular tonsillitis. In acute parenchymatous tonsillitis, they're uniformly enlarged, and sometimes they are so much enlarged that the whole cavity of the oral cavity is obstructed, just like this. This is a case of parenchymatous tonsillitis, right? And in membranous tonsillitis, a membrane is formed on the surface. The etiology is mainly bacterial. The hemolytic streptococcus is the most commonly infected organism that is causing this particular tonsillitis, right? So streptococcus is responsible for acute tonsillitis, often affects the school-going children. So now what are the symptoms? Everyone almost has experienced tonsillitis. So what are the signs? Everyone knows that we experience sore throat. We cannot speak. We cannot swallow, right? We are having fever, earache, and constitutional symptoms of headache, body aches, malaise, and constipation. They are constitutional, but the main symptoms are these. The signs and symptoms, signs are what we look, and as I've mentioned earlier, of different types. In follicular, there will be whitish spots, yellowish whitish spots, and in membranous there will be whitish membrane, and in parenchymatous there will be enlargement and congestion, so much that they almost meet in the midline, as I have showed you in this particular picture, this, right? Moving on to the treatment. So now what is the patient experiencing? We will be treating it like that. Patient is experiencing pain. We will be giving analgesics. It is caused by bacteria. We will be giving antibiotics, and plenty of fluid and saline goggles. These are important. These should be taken. These should be given in the treatment, right? So analgesics, antimicrobials, and plenty of fluids is the treatment. So what are the complications of the acute tonsillitis? So these are a lot of complication. You can remember by the mnemonic of CPSP CAR. For C, chronic tonsillitis, right? P for peritonsillar abscess. S for subcutaneous bacterial endocarditis. P for parapharyngeal abscess. C for cervical abscess. Acute otitis media, acute glomerulonephritis, and rheumatic fever. This is a sort of cram. Sometimes you can remember the 1 to 2 surrounding structures that okay, it will be causing chronic tonsillitis, peritonsillar abscess, parapharyngeal abscess, if it goes into the node, cervical abscess. But this is mainly remembered by this mnemonic of CPSP CAR. C for chronic tonsillitis, peritonsillar abscess, subacute bacterial endocarditis, and the parapharyngeal abscess, and the cervical abscess, acute otitis media, acute glomerulonephritis, and the rheumatic fever. The differential diagnosis of membrane over the tonsil. For example, if we are seeing a membrane over the tonsil, we are not going to diagnose it as okay, we'll be maybe diagnosing it as membranous tonsillitis. So what are the differentials that come in our mind? So the mnemonic is MAD while CTM. M for membranous tonsillitis, which everyone knows. But the other differentials can be epiphysis ulcers. It can be diphtheria. It can be Vincent angina. It can be infectious mononucleosis. It can be agranulocytosis. It can be leukemia. For C, it can be candidal infection. T, traumatic ulcer. M, malignancy of the tonsil. MAD while CTM is important to remember so that you can write the 10 points, and this is the DDs of the membrane over the tonsil. In this particular aspect, you have to remember in Vincent angina, when you remove the membrane, you see an irregular ulcer. This is something important. Infectious mononucleosis, for example, you're giving antibacterial treatment, antibiotics, but it is not curing, it is not getting treated. So then you also see that there is lymph node enlargement and splenomegaly. Then attention is gone to infectious mononucleosis because antibiotics are not working, right? So this is of viral origin, right? Paul Bunyan's test, monospot test is actually for the diagnosis. Right. Moving on, fascial diphtheria. As you know, diphtheria, Corynebacterium diphtheriae, we have studied in microbiology that it causes a membrane, it causes a lot of complications, like it can involve the nerves, leading to paralysis of soft palate, it can lead to the myocarditis, arrhythmias, and the membrane can cause the move towards the larynx, it can cause airway obstruction, right? So this is important. But how will you confirm that this is diphtheria, right? So you do throat swabs, and PCR is done for the diphtheria toxin gene, and there is a test known as the Schick's test, which was used but now used, right? Treatment is very important. In case of diphtheria, you have to give diphtheria antitoxin, right? Antibiotics are also given. Airway management is important in case of complication. Supportive care, and person is said to isolate because this can be transmitted, right? Diphtheria immunization booster is given. So this is the case of diphtheria. Moving on to chronic tonsillitis, this is important. It can be a complication of acute tonsillitis. In some cases, when acute tonsillitis is not diagnosed or it was subclinical, it can lead to chronic tonsillitis, right? Or there is some underlying surrounding infection of the teeth or the sinuses, it can also lead to chronic tonsillitis. It is of 3 types. Acute was of 4 types. Which one types? The superficial tonsillitis, and the follicular tonsillitis, and the parenchymatous, and the membranous. But here chronic tonsillitis is of 3 types: follicular tonsillitis, yellow whitish spots; parenchymatous tonsillitis, enlargement, sometimes so much that it is obstructing; and fibroid is the new thing. Fibroid tonsillitis is chronic in nature. The tonsils are small, but they are having a repeated history of sore throats, right? Recurrent clinical feature, patient will say that he is having sore throat but with recurrence, irritation in the throat, and the unique sign of chronic tonsillitis is halitosis, which is bad breath, right? Moving on to the examination. When you open the mouth, you see different things. Either it may be yellowish whitish spots, which will lead to the follicular type. Either they meet in the midline, which is parenchymatous, or either in case of fibroid, as I've mentioned earlier, that they're small, but when you press them, they ooze out the pus, right? So this means that this is a fibroid type. Flushing of the anterior pillars and enlargement of the jugular digastric lymph nodes is the reliable sign for chronic tonsillitis, because whenever there is chronicity, lymphadenopathy is a sign that you should have to keep in mind. Treatment, mainly we do tonsillectomy, because now things are getting worse, right? But conservative treatment is that we have to educate the patient to take care of his or her health and mouth hygiene and eating good things. Do not eat junk food. All these things have a very much impact on tonsils, right? The complications of chronic tonsillitis can be remembered by the mnemonic of PPT FIT, right? Peritonsillar abscess, parapharyngeal abscess, tonsillitis, and F for focus of infection, I for intratonsillar abscess, and the tonsillar cyst, right? Tonsillitis is actually calculus of tonsil. A stone or a food debris is obstructing the crypt of the tonsil, right? Diseases of tonsil are finished. There are some diseases of the lingual tonsil which are present at the back of the tongue, either acute lingual tonsillitis, either they are hypertrophied, or either there is an abscess. So this brings us to the end of tonsillitis. Hope you understand.